I'm Dr. Ahmed Lotfi. I'm a senior consultant obstetrician and gynecologist. I've been practicing in UK, New Zealand, and Middle East. This is a case of primary postpartum hemorrhage. The case summary is 39 years old woman in her first pregnancy delivered twins by ventouse. After delivery, she had heavy vaginal bleeding with clots, and by definition, this is a primary postpartum hemorrhage, which is bleeding after delivery and within 24 hours from birth. The uterus is soft and high, patient is tachycardic, pale, and drowsy. The diagnosis is primary postpartum hemorrhage, likely due to uterine atony. The causes of postpartum hemorrhage are the four T's: tone, uterine atony, most common, trauma, genital tract trauma, uterine rupture, cervical tears, vaginal and perineal tears. Retained tissues, placenta or membranes after delivery will cause primary postpartum and even secondary postpartum hemorrhage. Thrombin may cause primary postpartum hemorrhage, which is due to coagulation disorders. Risk factors. Multiple pregnancy is a risk factor due to uterine overdistension. Prolonged labor or instrumental delivery, another risk factor. Induction or augmentation of labor is a risk factor for primary postpartum hemorrhage. Retained placenta is a risk factor. Coagulopathy, which could be associated with preeclampsia, eclampsia syndrome, chorioamnionitis, intrauterine fetal death, is a risk factor of postpartum hemorrhage. Immediate management, call for senior help immediately. Resuscitation with ensuring airways. Airway should be clear. Breathing normal. Circulatory support with IV access to large pores cannulas. Fluids, IV fluids, saline, Ringer's lactate, blood transfusion, and transfusing blood products in cases of coagulopathy. Uterine massage is first management by manual massage to stimulate contraction and to control the bleeding. Patient should be monitored closely, vital signs and urine output. Medical management, uteritonics, oxytocin, 5 international units intravenously or 10 international units intramuscularly, then infusion, 40 units of oxytocin plus 500 ml saline, and give this in a rate of 125 ml per hour. Misoprostol, 800 microgram could control the atonic bleeding. Tranexamic acid IV is an antifibrinolytic agent which is proved to be successful to improve survival rate. Continuous uterine massage is mandatory, and by then we have to identify the cause of primary postpartum hemorrhage. Surgical interventions, if patient still bleeding, balloon tamponade, Becker's balloon is helpful, and if it is not controlling the bleeding, then laparotomy should be performed. B-Lynch compression sutures, could be successful, but we must make sure that the sutures are within the uterine wall, or the Becker's balloon will be ruptured. Uterine artery ligation and bilateral iliac arteries ligations will reduce the bleeding and control the postpartum hemorrhage. It all depends on your skills, training, and experience. Hysterectomy is a last resort, and it is a life-saving procedure. Key points: postpartum hemorrhage is an obstetric emergency, needs rapid senior response. 4 T's should be in mind: tone, trauma, tissue, and thrombin. First line, resuscitation, uterine massage, and uteritonics. Tranexamic acid early improves survival. Surgical intervention, bleeding uncontrolled, and depends about the surgeon skills and experience. This is the end of the presentation. Thank you.